different sources. Population data was drawn from Statistics New Zealand. So the accessibility scores derived from the three-step floating catchment area method were then ranked to 7 levels based on the standard deviations and formed the data for the first distribution map. These scores were then categorized, or the rankings were then categorized as low, medium and high accessibility and cross-tabulated with demographic variables at the SA2 level. So for Māori and Pacific ethnicity, these data also came from Statistics New Zealand, the census data, and were categorised at low, medium and high proportion ethnicity, where less than 10% was low, 10 to 20% proportion Māori Pacific medium, greater than 20% high. Socioeconomic data came from the NZ-DEP, also based on Statistics New Zealand data, and categorised at low, medium or high deprivation. And rurality data came from the newer geographic classification for health in New Zealand and categorised at urban, moderate or medium rural and very rural. So in this first map, you can see the areas of very low accessibility are the deep maroon. And in these areas, the weighted provided to population ratios were as low as less than 1 per 10,000 population, which is much like in developing nations. In the areas of very high accessibility, which are the dark green areas, some down through here and a little up in the North Island, the weighted ratios were as high as 26 per 10,000 population, which is well up with the highest in the world from Scandinavian countries. The average ratio across the country was just under 12 per 10,000 populations, which is somewhat higher than that in Canada, I believe, is around 7 to 8. So for Māori population, we're able to see where there's low accessibility down on this wee legend here. High proportion Māori population is this deep blue colour, and that's largely around the central North Island, this east coast area and up in the far north. So these are target areas for interventions to increase physiotherapy workforce deployment. For Pacific population, areas of, again looking at the legend, low physiotherapy accessibility, high proportion Pacific, again this deep blue area, are primarily concentrated in a couple of small rural communities. Pacific people overall are more concentrated in large urban areas where there's also more large public hospitals. So there's fewer poor accessibility areas that show up. However, there's known failings of the census process that has very poor capture of Pacific ethnicity and Māori. So even where there's low accessibility and medium proportion Pacific or even medium accessibility, those areas are still, in those urban areas, targets for health workforce interventions. Looking at the areas of high socioeconomic deprivation and low physiotherapy accessibility, again the deep blue, these tend to be concentrated where in those same areas where there was quite high proportion Māori, east coast, far north, a little bit around the central North Island. Because of this interaction between Māori, low socioeconomic and rural areas, we did find an overall country level statistical association between Māori ethnicity and low physiotherapy accessibility. Not so much for the other factors though. Very rural areas, again this deep blue with low physiotherapy accessibility, also mirrored that central North Island, east coast, far north, but also included large swathes of the South Island of New Zealand, with exception of some much wealthier areas around resort towns in the South Island and this South Canterbury area here as well. So in conclusion, our problem in New Zealand is really one of physiotherapy workforce maldistribution rather than shortage. And this begs a different response than if workforce shortage was the main problem. In New Zealand, the majority of physiotherapists work in private fee-for-service models, so the market forces play a major role in where they're located. At least the three-step floating catchment area method provides us with a way to conceptualise what the problem looks like and where health workforce interventions need to be targeted. The weighted provider to population accessibility score is a robust method to capture opportunity to access care in terms of both distance barriers and the competition from surrounding population. Poor quality and lack of organised sources of data were the main limitations. We don't know the capabilities of the workforce at their locations, or FTE for example, and it is a lot of work to reassemble this data set for longitudinal analyses, which is where much of the value would lie. We are able to differentiate between public and private facilities, and integrating this will be a next step. So again, these are the fantastic people I've had the pleasure to collaborate with, and I'm very grateful for. Thank you.
Thank you so much, Dr. Buhler. Really neat work. And we already have a comment from Charlene. Thank you for the beautiful, informative, and easily interpretable maps. Any questions for Dr. Buhler? Stefania, please go ahead.
Thank you. I actually typed my question in the chat. I was actually wondering, seeing the differences that you were pointing to, is the life expectancy and the general morbidity of the Maori population comparable to that of general population in New Zealand, or are there differences in between the two that would impact your statistics? I'm thinking, you'd mentioned, if I followed at the beginning, that the population over 65 is more likely to use the physiotherapy services. So what is the proportion of Maori population over 65 and in need compared to the general population?
The Māori population and also the Pacific population in New Zealand are younger. Both they have shorter life expectancy by about 7 years compared to non-Māori, Māori do, and they also have they're a more youthful population, so higher birth rates as well. So the shape of the demographic is much different to non-Māori population. So for health conditions that affect older people, mobility issues, arthritis, and so forth, yes, there'll be differences in access just based on age, but Māori and Pacific have much higher rates of cardiac disease, respiratory disease, diabetes, which afflict them at much younger ages. So the need is certainly high there. And they also tend to be more, there's more Māori and Pacific in manual work where the risks are much higher. So much higher injury rates, and just in terms of that labour workforce, injury and morbidity in work is about 4 times higher in New Zealand for Māori than even in Australia. So there are lots of issues in employment regulations and health and safety, for example, that impact on the health burden for those populations. So we know that the need is high, but the access or the accessibility of care is not what it should be to address that in New Zealand.
Thank you.
We have a comment from Dr. Nigel Waters, and I totally agree with that. Great presentation with several important policy opportunities identified. Well done. And a question from Jojo. Three-step floating catchment area is sensitive to the choice of distance decay function. Did you do any sensitivity analysis regarding this? And do rural and urban areas have different weighting scheme?
No, we haven't done sensitivity analysis for that, and we haven't differentiated between rural and urban settings. And it is a piece of work to do in New Zealand. As I mentioned, that the data we base that on is mainly from outside of New Zealand. So there's certainly some research questions around what is travel tolerance for for Māori and non-Māori, for example, in rural or urban settings. Yep, work to be done.
Thanks.
And there is a question. Please define for the audience what constitutes Pacific.
Sure. In New Zealand, there's a diaspora population, so people who have moved to New Zealand over the past almost kind of 8 decades from many Pacific nations, mainly Samoa, Tonga. The Cook Islands are part of the New Zealand nation, but other Pacific islands are not. So they've come as work migrants over many decades. Many now are second generation living in New Zealand and New Zealand citizens. So there are also many Pacific people who are newer to New Zealand on migrant visa work. So the majority captured in here are diaspora populations who live here. There's also a proportion who are migrant workers from the Pacific Islands.
Thank you so much, Dr. Buhler. Really fantastic work.
Thank you.
Thank you for joining. It is really unfortunate that we were unable to see the presentation